Hello, I'm Dr. Mel Crane from the University of Sydney. I'd like to acknowledge the Darug people as the traditional owners of the land I'm speaking from today. I'd like to present to you two pieces of research I conducted for the Australian Prevention Partnership Centre to understand more about how we can sustain action for NCD prevention at the population scale. Firstly, what do we know about sustaining prevention programs? We know it's a challenge. Effective programs are maintained, they evolve or are terminated as funding, political or organisational priorities or public support changes over time. And termination may be an appropriate policy or resourcing decision, but more often programs terminate as a result of a lack of ongoing funding or support from the policymaker, agency leader or community. If premature, the program may fail to result in intended health benefits and be a waste of public investment. Now, various reviews have identified certain factors which determine program sustainability, including the innovation or intervention characteristics, for example, various intervention components and its costs, or the delivery settings, such as characteristics of delivery organisations and the processes like training staff. Then there's the inner contexts of the organisation providing the program, their characteristics, funding and resourcing, leadership, support and policies, and the outer contexts, including the social political environment, policies and legislations. Various studies of frameworks have suggest that these factors determine if a program will be sustained. However, this is a very linear understanding of cause and effect. And what we don't know is how population health programs, which generally involve the whole system of organisations, levels and settings, are sustained. What we do know about preventing chronic diseases across the population is that it involves long-term intervention, often addressing multiple lifestyle factors, and usually a range of settings. The literature on determinants of sustaining interventions has broadly come from small-scale interventions delivered by single providers in single settings. They take a very linear view of determinants and may not apply to population health programs comprising of complex systems of multiple actors and agencies involved across multiple levels. And it's this interconnectedness of processes and relationships that enable programs at the population level to run the way they do. Now, the evidence is also developed from evaluation studies from the first few years of implementation. So what we really know about determinants which has informed various frameworks and models, is only relevant to the first few years of an intervention's lifespan. So the aim of this research was to fill this void and to investigate factors which determine how population health programs are sustained. In the first study, I used qualitative methods to explore the system for sustaining population health programs. I conducted interviews with population health prevention managers and decision makers working at the local, state or national level in government and non-government agencies to understand their views from the various levels of delivery. So I identified 4 key barriers, and the first was that short-term political or funding cycles. So interviewees explained that while population health programs are designed to change health behaviour and reduce NCDs, generally require a long-term program effort. Yet we implement short-term goals, rely on short-term funding and produce programs with limited capacity to improve health. This short-termism in planning and funding and time-bound commitments was noted to breed bad habits and lead to staff insecurities, which in turn led to short-term workforce and corporate memory loss. Another key challenge is the volatile political environment with reoccurring cycles, which often means accepting short-term wins. The second barrier was competing priorities. Prevention programs compete for funding and resource with other areas of health, which may be able to show more immediate or visible short-term impacts. There is also some feeling that prevention is viewed low on the pecking order compared to other health conditions and services. Participants recognise that senior leadership strongly influences the extent to which health promotion programs were supported or sustained, and whether senior executives actually had experience and understanding of the role of health promotion. Where organisational political leadership failed, Public or community support may also influence decisions to sustain funding, especially if the program is well known in the community. The other area is competing priorities, and these were mentioned outside the health sector. So population interventions, modifying NCD's lifestyle risk factors need to work outside the health system to influence change. Some mention the competing priorities of other sectors of government, yet the need to work with them was necessary. An example, something like reducing alcohol risk, which is often under liquor licensing and governed in many states by a different government department that does not have health as its priority focus. The third barrier I've called silo thinking. So passing responsibility to another organisation or part of an organisation may be seen as sustainment. This is noted as a common mindset that as soon as fiscal responsibility of a program was transferred to, say, the local health services, state responsibility seemed to end. This compartmentalised view of programs was reflected in views about funding. Funding was either seen as critical or mildly necessary to sustain programs, depending on the level within the health system the person worked. For someone at the macro level, they could implement policies without funding. But for those in local health services, programs needed funding to be sustained. Failure to recognise the role and value of each part of the system required to implement and maintain large-scale programs created large tensions between levels of government and between, say, government and non-government organisations. The final barrier I note here is the fit for program to the population needs. Managers are generally responsible for a suite of prevention programs, and often there's an overriding larger need to sustain prevention activities in general at the cost of individual programs. But when it comes to individual programs, they're often designed for a specific purpose and format, and this makes them difficult to adapt to changing population needs or to align with new priorities. And this is why it was considered necessary to retire programs. This also led to some caution in developing long-term partnerships. Delivery of population health programs at scale by state or national teams across local health services offered advantages over, say, localised small-scale programs in withstanding termination to, say, political pressures, especially if they had a greater public profile and central implementation structure. But they needed to fit with the local population context, and a one-size-fits-all program without tailoring to local population needs doesn't enable that. So several approaches were used to overcome barriers, and I won't run through these, but I encourage you to read the new paper. I want to move now to the next study, which was a quantitative exploration of real-world long operating programs to learn from practice what it is that determines long-term sustainability. This study focused on population programs that have been implemented, at least at a city scale, to prevent NCD lifestyle risk factors. We identified interventions by going through published literature and systematically searching for names of programs. We then looked for program websites for information in English that we could extract on the program, and we used this information to populate a database on key theoretical determinants, such as I've mentioned earlier. So we collated information on 90 programs. The longest had been operating for 37 years, the shortest for 4 years. The majority targeted children, few targeted the general population. The types of interventions included education programs, capacity building, information provisions, behavioural skill programs, etc. The main delivery setting was in schools and early childhood centres. Provider organisations included health and other government departments, universities, not-for-profit and private organisations. And many interventions were at the national or state scale, but some also internationally delivered. I analysed the relationship between the number of years a program had been sustained and found that those sustained more than the average 15 years were mainly from the US and Canada. In comparison, few Australasian or European programs had been sustained as long. The type of interventions sustained longer were behavioural skill programs. There were also programs with an interactive component rather than static resource. Programs had predominantly undergone some form of modification over time, They're also more likely to be commercially funded programs. Fewer government or non-government programs were sustained as long. Finally, fewer longer-running programs involved partnerships or were supported by community involvement. There are just a couple of implications I want to mention. Firstly, we need to take a systems perspective on programs, planning, funding and delivery to improve sustainment. Well, what is systems thinking? It's about trying to understand how interventions all work within a complex system, in this case, the health system. System thinking is really the opposite of silo thinking, and it means having flexible, agile programs, resourcing, making use of partnerships, overcoming short-termism in how we plan and fund programs, using but not abusing the system levels, and being equipped for change through good leadership and adequate research to plan for sustainability from the start. Now, my second point reflects on the existing research knowledge. We need evaluation studies which look at the program impacts and outcomes beyond the first few years of program lifespan. And research also needs to look more at the system and system level influences on program, making use of systems methods and tools to do things like identify where the pressure points in the system are, where to inject resources or limited funding to the greatest effectiveness, so that we can sustain good programs well. Thank you for listening.